Lately, I've noticed the announcement of a lot of new accountable care organizations. Somebody counted them up and said as of the new year, there were 125 accountable care organizations that were in development, which is pretty good. But when you consider there are about 5,000 hospitals, we have a long way to go to find out how this whole thing is going to work out. Of course, in 2012, we start the 3-year federal demonstration project, and I'm guessing there'll be maybe 24 organizations chosen to demonstrate different methods. The real question is, what are the other 5,000 hospitals going to do? I've been a proponent of cooperation in building accountable care organizations because I think the impetus to be competitive with your local crosstown rival really wastes a lot of time, money, energy when the federal government needs us to coalesce and figure out how to manage care much more effectively and, yes, much less costly than we ever have in the past. Hospital organizations have been grown on the basis of annual increases in Medicare rates that translated also into increases from private insurance. But the federal government announced a 10-year regime of Medicare price reductions. So every year for the next 10 years, they plan on cutting, not raising, the amount of money that is given to hospitals. And they keep putting off the idea that they believe in of cutting rates to doctors. It's just politically almost unpalatable. The time will come when that will happen too, because the only way the gross national product gets re-engineered is if the federal government spends relatively less money on health care. So our field needs to tighten its belt and get used to the idea that the free lunch is over and we're going to have to be able to do better and more with a lot less. So creating competitive organizations and infrastructure that's highly expensive, like the computers and software and training that goes into creating accountable care organizations, doesn't make a lot of sense to me. And I think a lot of announcements right now by large physician groups, primarily independent practice associations, and standalone hospitals that they're going to start their own ACOs, is a lot of saber rattling, basically. I think we'll see a shakeout over the next 24, 36 months of organizations that finally get around to the notion that you can compete, but you've got to cooperate on the infrastructure. You can compete on quality, you can compete on price and location and breadth of service, but you have to be able to work together on the infrastructure, which has no return and which needs to be designed to be as objective and Swiss-like in its objectivity as possible. So I see competitors in markets coming together and creating one unified accountable care organization. And I see large regions where it will be possible to put together geography that's never been conceived of as one common market. In fact, they won't be common markets. They'll just be common, shared overhead costs to help organizations achieve the level of quality that we all hope is possible. Now, this is kind of ACO 2.0. A lot of organizations are essentially being told anybody can start one of these. You know, one of the regulations that set off this kind of land rush was the regulation or the statement in the legislation itself that you only need 5,000 covered Medicare lives to qualify to start an ACO. But if you've had any experience actuarially or with capitation or both, you know that 5,000 is a very tiny risk pool and that you need much larger numbers. Really, hundreds of thousands of lives would be better than tens of thousands of lives. So, and I suppose millions of lives is better than that too. I can see in some parts of the country, if allowed, there will be multi-state ACOs that will be needed. in areas with low population, like some of the mountain states, or geography like the Northeast, where there's a dense population, but regulation has gotten in the way of creating efficiencies. That will take, I'm sure, some federal antitrust action that will make it easier for organizations to work together. But I can see that that would happen. So, bottom line is, when you hear your hospital talking about an ACO, ask them, have you considered cooperating with other organizations to keep the cost of this new thing low? Because we want the highest quality possible, and we don't want to spend money on infrastructure that doesn't help that. Discipline and courage, that's what this takes.